Hello, everyone. My name is Dr. Mary Moeller. I'm an associate professor of nursing at Pacific Lutheran University in Tacoma, Washington, where I am also the coordinator of the Psychiatric Mental Health Nurse Practitioner Doctor of Nursing Practice Program. The program that you're about to see is part of a two-part series that I have recorded for the Healthcare Authority in collaboration with New Journeys and WISE team members. The title of today's program is From the Couch to the Bus Depot to the Mall to Work, the relationship of post-psychotic adjustment to recovery. This program was based on my doctoral research at Case Western Reserve University. I've broken this into 5 modules, about 25 slides per module, so it's designed to be interactive and you can discuss with one another as you are viewing these modules. This particular program is part of the MAP recovery model, which stands for Milestones of Adjustment Post-Psychosis. I became interested in this topic when I was in Spokane at our clinic, the Suncrest Wellness Center, and I started giving patients a newer medication in early 2000. And these folks all had schizophrenia. That's been my research interest ever since I have been in psychiatry, which is 1978. And I noticed these folks starting to get a new level of awareness, and they were angry, and they were upset with their family members, and they were particularly upset with the fact that the folks had to call the police when they were first ill. They couldn't get into a doctor. And I thought, my goodness, this is 15, 20 years after the first episode, still angry. And so I got an IRB approval to study what I call the impact of psychosis questionnaire to discover what was really left undone in their lives. What were they experiencing? And what I identified was that people were not able to adjust to the fact that they'd had a psychotic episode. And this really came down as a result of one particular narrative. So as part of this project in implementing the impact of psychosis questionnaire, I noticed that, I had a narrative question, is there anything else you want to tell me? And there was this one young man who had written, how would you like to know that when you were psychotic, you didn't know what was going on, and all of a sudden your parents call the cops, and the police come, and the fire trucks come, and the rescue squad comes, and all of this chaos is in your neighborhood, and you're dragged out of your house, you don't know what's going on, thrown into a cop car, sent to a mental ward, drugged up, and then you are discharged, and you still don't really know what's going on, and all of a sudden you're supposed to put your shoes on and go out the front door knowing what your neighbors saw. And when I read that, I started crying. I thought, oh my goodness, I've never thought about it like that. I've always been the cheerleader, okay? Let's rah-rah, let's, get your meds straightened around, let's get you finished with that GED, get a job, and get on with your life. And I just never really understood what was happening with individuals that I labeled as being stuck. And when you know that this person could do better. And so I thought, this is all about adjustment. Then I thought, well, how would you adjust to having had a psychotic episode and being diagnosed with schizophrenia and you're 18 or 19 years old? So I did an exhaustive literature search on what I labeled post-psychotic adjustment. There was 0 in the literature, 0. There's, all kinds of studies on adjusting to spinal cord injury or suicide or amputations or cancer. No one had published anything on adjusting to psychosis. There was a lot about coping with psychosis. So I thought, I need to do this study, and I want to get academic credit for it. So I went shopping for a university that would help me do this dissertation, and I went to Case Western Reserve University in Cleveland. And my data was collected, and all my clinical part was done at the EAST program, is what it was called at the time, down in Salem, the Early Assessment and Support Team, which is now the EASA program, which I know that many of you are very familiar with. So I'm forever indebted to Tamara Sale and the clients and participants at their headquarters office in Salem, Oregon. So with that bit of an introduction, we're going to begin, and we'll go to the first slide in the module. Oops. We're going to look at our objectives. We're going to talk about the phases and categories of milestones of adjustment model. We're going to talk about treatment milestones and interventions that are related to each phase. And we're going to talk about implications of this model for members of the treatment team and the mental health system. I've been teaching this model and implementing this model myself in our clinic for over 15 years now. The original work was done with schizophrenia, but I've adapted this model to folks with all different psychiatric illnesses. And then finally, we're going to use the treatment guide, which you have, to develop a psychological recovery map for selected clients. I'm going to ask you to implement this in small groups as we did in the major workshop. And hopefully you will find a new way to work with your clients. So this was the agenda for the all-day workshop that went from 9 to 4. And obviously, I won't be building in these breaks. We'll be going through the modules exactly as was done in the workshop in June of 2020. So we'll talk about the initial study and the definitions that I use. So I already gave you information about the study. So I'm defining recovery as the return of something to a normal or an improved state after a setback or loss. And I love this definition. It was a psychiatrist friend of mine in Texas that said he actually looked at recovery as a recover, which is to put a new cover on something or to cover something again. Sort of like recovering a piece of furniture, only he's talking about putting on this new sense of self, this new person. I think it's a really beautiful way to think about recovery. And then we want to look at resilience, which is the ability to recover quickly from a setback. And adherence, which is following rules or instructions to keep to an agreement or to hold firmly to your belief, idea, or opinion, which I like the last part of this definition, which is really working with the client to think about what is your ideas, your beliefs about recovery. What does that mean to you? And a milestone is a significant point in the development of something. So part of my drive to do this study and come up with this model was, as a nurse, we always would give people, prognoses, okay? You've had a heart attack, we're going to monitor your heart, you're going to be able to eventually start getting on a treadmill, and we're looking at 1 month, 3 months, 6 month recovery points. Same thing with a stroke. Well, you should be at this point in about 6 months. Give people a target to work toward, right? So what about with schizophrenia? What do we say? Take your medicine, go to the mental health center, hope you don't have another relapse. Never really could give anybody specifics. So that was another aspect of the study that I was after. And I did come up with 50 milestones over the course of recovery, which can go up to 3 to 4 years after that first episode, and looking at phases in which a person goes through reclaiming their self, reclaiming this sense of self, putting on a new cover. I've had this psychotic episode. There was this big thing in my neighborhood. Everybody knew it. So that's what I'm about to share with you. So, some overall aspects of the MAP recovery model. Adjustment, psychological recovery, is multiphasic and takes 3 to 5 years. And I was really shocked when I was doing the initial literature. It was really looking at, okay, there was 1 year, 3 year, 5 year markers in the first episode treatment programs. And I thought, oh, it can't take that long. It really can't take that long. Well, it does. So when you think about totally losing your sense of self in a psychotic episode, And a lot of this is dependent on how long was a person psychotic before they even got into treatment. So when I'm using the word psychosis here, I'm talking about, it could be a psychotic break related to schizophrenia. It could be a psychotic episode of mania, depression. So schizophrenia has the longest recovery trajectory because there's so many deficits that can happen in the brain. Bipolar psychosis recovers fairly quickly, as does a major depressive psychotic episode. But the principles are the same, which we'll be going through. There are cognitive, emotional, interpersonal, and physiological milestones that a person needs to strive to complete. And so in order to make this map successful, the person needs to be able to engage in both therapeutic and social communication. Not just, yeah, no, okay, whatever, you tell me. There needs to be empathy on the part of the family and caregivers. True empathy, where you are really trying to understand this other person's lived experience. Needs to be good medication efficacy. If there isn't medication response, the person isn't going to do as well. And we know that the antipsychotics are only helpful for about 75% of people. The other 25% have such a serious brain deficit that it's going to be really hard for them to move very far along in recovery. Those are the folks that we know that will need probably 24-hour supervision most of their life. Those are the folks that never return to baseline after that severe first episode, which is why the early episode case finding is so critical. If we can get folks early in that first episode, they're going to have a better outcome. Need to feel that there's encouragement. Positive outlook by the consumer as well as the staff and family. And to be able to accept that, yeah, I've got this diagnosis. And that doesn't happen right away. That takes time. And by all means, requires family support. And those are our prerequisites. A model that is useful in understanding the piece of recovery that I was after in this study is from Larry Davidson, who runs the program for community recovery at Yale University in New Haven. And I know Dr. Davidson. I actually taught at Yale University for 6 years and had the privilege of working on a grant with him. When you do a qualitative study, such as I did, you only do a little bit of a lip search to identify that there's a need for this study. And then you do the exhaustive literature search, at the end. So at the end of my study, I found this marvelous book that Dr. Davidson had written, where he had interviewed 100 people with schizophrenia. And this is his model. So he identified that, first of all, this person had a life before their illness. Okay? All of our people have lives before their illness. And then there's these cognitive intrusions that occur. Function starts to decline, and the person goes down this internal spiral on the inside here, where they're having delusions, idiosyncratic ways of making sense, and increasing withdrawal and isolation, demoralization and despair, and this horrific loss of a sense of self and increased vulnerability. They get into treatment, something happens here, and wow, they have found out ways of making sense of this intrusive thinking and this disruptions. They learn to cope. And then there's belonging and hope and success, and this person moves along the way, and they're adapting. So what I actually teased out in my study was this yellow area. How does a person make sense of having had this horrific psychotic episode, a hospitalization, and how do I put my life back together? So the title of the study was Psychophenology, the lived experience of people with schizophrenia in the post-psychotic adjustment phase of recovery from psychosis. And you can read a pretty in-depth, long, published a 13-page article manuscript in 2011 that has quote after quote after quote, many of what you're going to be seeing in this workshop today, published in Archives of Psychiatric Nursing. So the folks in my study had to be at least 21, so I didn't have to deal with IRB issues. They had to be enrolled in that program for at least a year. They had to be able to make decisions, so it couldn't be actively psychotic. They could certainly have psychotic symptoms, but needed to be able to have adequate decision-making capacity, speak at least conversational English, and have evidence of a high school diploma or GED, or they were working on it. So in other words, I needed a sample of individuals, participants that could communicate well with me. So this was my primary question. What's the lived experience of people with schizophrenia in the post-psychotic adjustment phase of recovery from psychosis? And secondarily, I wanted to know if they'd adjusted or not adjusted after their diagnosis, what were critical points in time that may signal there had been a delay in their adjustment, what factors delayed the phase, what were unmet mental health care needs that contributed to delayed adjustment, and then what aspects of treatment helped and what aspects hindered. So the interview questions, and I encourage you, use these questions. You'll learn a great deal of information. So the first question was, what has your life been like since you had a psychotic episode and were diagnosed with schizophrenia? And the participants all had these questions before the interview, because that was part of the consenting. And they actually were kind of lined up to be in this study because nobody had ever asked these kinds of questions before, and they wanted to talk about it. Second question was, since having a psychotic episode and receiving this diagnosis, what does adjustment to life mean to you? And then I had to modify that question and just say, what changes have you had to make in your life because of schizophrenia? Then I asked to describe points in time that have been important in adjusting to life since this episode. Because so many people said, by the time I was 21, I wanted to graduate from college, or I'd hoped to move out on my own. So you get a sense of who that person is. The fourth question was anything missing from your treatment that would have helped in your adjustment to having a psychotic episode? And 5, is there anything else you want to add? And that's always a wonderful question to ask. So I encourage you, use some of these questions just in your everyday conversation with your clients. So the methodology was developed by Dr. Adrian van Kam, who was a Dutch psychologist that escaped Nazi Germany and came to America, to Pittsburgh, and started Duquesne Phenomenology Center. And he had actually studied classic Husserlian phenomenology. So the goal of regular phenomenology is to produce a description of a phenomenon in order to understand its structure. Whereas psychophenomenology, which Dr. van Kam developed, placed the emphasis on the internal psychological world of a person by identifying what he called the necessary and essential constituents of the phenomenon. So in learning about him, I learned that he did his doctorate also at Case Western Reserve back in the 50s. So I was able to dig out his original dissertation. And of course, in the 1950s, there weren't word processors, and Case Western's a very quantitative school. They made him do 250 interviews. They had to sort through without a word processor or a computer. And his question was, how do adolescents know that they are adjusted? So I thought it was just kind of interesting that he was studying adjustment and I was studying adjustment, and it felt really good. So in my interview, I ended up with 10 that met the criteria, had 542 responses that had something to do with adjustment. And the initial reduction of all of that was 7 potential necessary and essential constituents. So what I found, I could group them into symptoms and getting into treatments. There were 84 responses related to that, 64 on how they personally responded to their symptoms, 80 on how they figured it out, 174 what helped, 59 what didn't help, 36 how I know I'm not adjusted, and 45 how I'll know when I am adjusted. And I eliminated that first category on symptoms because there's been a lot of research on that. So I looked at these 6 categories and all of these responses to begin to get a sense for what are the necessary and essential constituents of adjusting to a psychotic episode. So you go through this process in qualitative research of reducing and eliminating. So I was able to collapse those 6 categories into 4 constituents. And the first one was how they recognize the effect of the psychosis on their daily functioning. And then I used Festinger's cognitive dissonance work and really found his definition, which I'll go into in a little bit, about cognitive dissonance as really helpful in looking at psychosis. Then the second constituent was, okay, now they gained an understanding of the relationship of symptoms to actual reality, which I named insight. Then I looked at the third category, which was how they achieved stability in their thinking and responding to others. And that, again, is Festinger's work on cognitive constancy. And the fourth category was how they learned to perform age-appropriate ordinary activities of daily living. And I named that ordinariness. I actually, when I was looking at this, I had asked my husband when I was going through all of this, I said, is there such a word in Webster's as ordinariness? Because that's what my participants were talking about. They just wanted to do ordinary things. And so we looked it up in Webster's, and sure enough, there is a word, ordinariness. So these became the 4 phases. And I later on then put that into pretty measurable terms, and it became from the couch to the bus depot to the mall to work. So I'm going to tell you how we got there. So here's the 4 phases: recognizing emotional, interpersonal, cognitive, and physiological states that indicate psychosis-induced cognitive dissonance, gaining insight into the behavioral incongruencies that result from psychosis-induced cognitive dissonance, evident by emotional, interpersonal, cognitive, and physiological outcomes. For example, one of my participants developed his psychosis when he was 16. He was delivering pizzas, and he started having ghosts following him wherever he went, and ghosts in his pizza delivery car. And he ended up living across from a cemetery. That's where his parents' house was. And he thought, well, maybe if I didn't live by a cemetery, I wouldn't have ghosts. So this is an example of someone that recognized that there were these states going on, and then through the course of his illness, he got insight into that. And he obviously ended up not driving, a pizza delivery car anymore, and he ended up dropping out of school, and then became very ill and got into this program, and he's doing quite well. The third phase is achieving cognitive constancy through a change in attitudes and beliefs. So Festinger's work is really looking at how attitudes and beliefs affect our sense of self, our ability to evaluate reality. I would encourage you to read more of Festinger. And so that this change is achieved under the guidance of a safe and successful treatment program, and it culminates in establishing ordinariness. So how the final responses broke down, I was able to collapse those into 50 specific milestones. We don't call them themes because I did not do thematic analysis. I was looking at this cognitive process using psychophenomenological steps. There's 10 steps to manipulating the data in von Kamm's model. And also his model requires not only that you have an external committee, such as my dissertation committee, but I had to go back to the participants twice during the data analysis to get them to validate, should I be putting this under cognitive? Should I be putting it under emotional? And they corrected me on several areas. So it was then I had to have outside readers. So there were 6 PhD level folks looking at the data and my analysis and my consumer population. So I feel very confident about my results. So what happened was there were 159 responses in the emotional category, which collapsed into 17 specific milestones over these 4 phases. 135 responses that had something to do with cognitive processes, 106 that had to do with interpersonal processes, and 58 related to their body functioning and their physiology. So we're going to take a look at them. Okay. In the 4 phases across the top and the types of milestones on the left, we're looking at 5 big themes, or excuse me, milestones that came out in the emotional phase in cognitive dissonance, but only 1 in the insight phase, 8 in the stabilization, the cognitive constancy phase, and 3 in ordinariness. So emotion was quite significant in the first and third phases. This is the acute psychosis recovery. This is where the person is beginning to engage going back into public, which I'll get to in a second. Cognitively, there was only 2 in that first phase, but 5 in the insight and 6 in cognitive constancy. So if you think about this first phase, cognitive dissonance, when the person is in a hospital or early in treatment, we need to be paying attention to their emotional self. This is not the time to be doing a lot of education, a lot of didactic on, what are your symptoms, what are your meds, because the person is very, very emotional during this phase. And interpersonal, isn't that critical? That really comes into play over here in cognitive constancy. And the taking care of your body, the biggest part of that was also in this cognitive constancy. So we'll go into a little bit more depth in those. Whoops. Oh, excuse me. This is the end of this first module. So, and these are the exact slides from when we recorded before. So whatever you're doing, have a little discussion about this, and I will come back and see you at the next module.